Hello everyone, my name is Aaron. I am a tutor on Wyzant and I'm going to be covering a pathophysiology question for healthcare professionals. This is a question I made myself based off of my experience as a nurse. I am a family nurse practitioner and this is completely a hypothetical situation. John is not a real patient. I will, however, go through the Wyzant online platform. You'll see how I share resources, how I break down a specific question. So let's go ahead and get started. John, a 45-year-old male, walks in the clinic complaining of persistent angina that started at 1 a.m. in the morning. He's notably diaphoretic. He's still ambulatory and alert. He's a smoker with a pack history of 15 years. He's no allergies and medication. His medical history is unremarkable except for hypertension, fixed lisinopril, once daily only. EKG is performed noting abnormalities consistent with an anterior MI. What findings might you see on the EKG, and what would be an appropriate intervention? Okay, let's take a look at A. Normal sinus rhythm with a pathological Q wave, call EMS. Well, let's see. So the EKG is noting abnormalities. So if we're noting abnormalities, yeah, okay, we have a pathological Q wave, which could mean an old MI, or it could mean a current MI. But if it means a current MI, we're not necessarily going to have normal sinus rhythm. That's not going to be the case. We're going to have ST elevation with or without reciprocal ST depression as well. And we're going to go ahead and go through that. So let's bring up some resources here. This is a resource that we can use to go ahead and look at. This is essentially an example of a 12-lead EKG, and we'll see our V1 through V6 leads here. And so for an anterior MI, what we'll see is we take a look over here where the red is, this ST elevation here, and here, two contiguous leads, way off the baseline. Man, yeah, very high here. And we can also see that we have ST depression over here, leads 2, 3 AVF. These are called our inferior leads. It's the inferior wall of the heart. But that would be consistent with what we would see with an MI. And so if we go ahead and go back to share screen, this would not be the right answer because this EKG is showing abnormalities. Now we can have an MI that is an NSTEMI, meaning that the patient is not having EKG changes. These patients generally are older, they have atypical symptoms, weakness, nausea, and to assess for an NSTEMI, we want to go ahead and do cardiac enzymes, right? We'll be looking at things like troponin. Is the troponin elevated? Yeah, we'd be concerned about the possibility of an NSTEMI. So A is not the right answer. Let's take a look at B. Notable ST depression in the inferior leads. Okay, yeah, we can definitely have that. But where is our ST elevation in our anterior leads? We know this is an anterior MI, right? We would expect that to be the case, especially with abnormalities. Provide 325 milligrams ASA, aspirin, and wait 50 minutes for improvement in symptoms. So no, not just ST depression. Would you provide aspirin? Yeah, absolutely. But we wouldn't wait 15 minutes for improvement in symptoms, right? We're not going to go ahead and give them some aspirin and say, hey, before EMS gets here, I'm going to go ahead and run to the restroom, and we'll see how you do when I get back, right? Are you still going to be alive? You'll be fine. And then walk away, right? No, we're not going to do that. So B is not the right answer. Let's take a look at C. ST elevation in leads 2, 3 with reciprocal ST depression leads 2, 3 in AVF. We talked about that, right? Call EMS and then provide 325 milligrams aspirin. Yes, absolutely. C is the correct answer. Call EMS and then provide 325 milligrams aspirin. Let's call EMS. Let's get them on the way first, right? Let's give them that aspirin immediately after. This should be a very short time frame when that's done. So one of the things about aspirin as well, it's a COX inhibitor. I'm going to go ahead and screen share covering. This is from a personal resource of mine, but it kind of talks about the main things are MOA for aspirin and other medications uses, adverse effects, contraindications, et cetera, et cetera. But we can see here that, in fact, ASA is a non-selective and irreversible COX inhibitor, and we'll use it to decrease the risk of stroke, or even in the context of somebody who might be having what we suspect to be an active MI. It can increase or actually decrease the risk of mortality. So let's go ahead and do this. Let's go back. All right. And so C is the correct answer. Let's take a look at D. I always want students to go and go through the entire answer choice. Okay, take a picture of the EKG, send it to your friends, ask them for help to figure out what's going on. While it's doing so, tell John to relax because you're waiting for a response. Let's hope you don't choose D, right? If you're the type of student who, is on their Twitter feed trying to go ahead and show people pictures of an EKG because you need help, and John is gasping for air saying, help me, and you're like, John, hold on 1 second. Let me go ahead and get a response back in my Twitter feed, and I'll get back to you. No, if you're doing that, you're not really a student I'd be able to help out. I'm not sure who could help you. But yeah, my name is Aaron again. I am a tutor on Wyzant. You can go ahead and reach out to me if you need any assistance with pathophysiology. I'd be more than happy to help you.